Hello and good evening. Welcome to the Adults and Health Scrutiny Board, Tuesday the 11th of November at 6 p.m. We've got just one apology, have we, Lindsay? Yeah, from Councillor Khan. I'm not aware of any late items. Are there any declarations of interest? Move on to item 4, the minutes of the meeting. I just wanted to go do a quick round robin, if that's okay, just to do quick introductions, because there's a few faces that I don't recognise, and it would be good to just go through. So, as a reminder, I'm Councillor Nicola Ralston, Spondon Ward, also chair of this meeting. And if we go,
yeah, sure. Hello, everybody. My name's Councillor Jamie Mulhall, and I represent Open.
I'm Councillor Amy Lonsdale of Little Over Ward.
Hello, my name is Lee Rinder. I'm Managing Director at Derbyshire Healthcare Foundation.
Good evening, my name is Beek Rupert. I'm the Associate Director for Mental Health, Learning Disabilities and Children's Commissioning for Derbyshire ICE.
Hello everyone, Sean Thornton, Director of Communications and Engagement, Derby and Derbyshire ICB.
Hi everyone, I'm Beth Fletcher. I'm Engagement Manager in Integrated Care Board.
Councillor Martin Repton, Darley Ward.
Councillor Carmel Ashby, Abbey Ward.
Karen Jitcho, Head of Mental Health and Occupational Therapy, Family Social Care at opposite the Council.
Hi everyone, I'm Sunita Binning and I'm the Contracts Manager for 6 England House Mid Mercia, and we are a co-commissioning partner, BCSE.
Councillor Richard Hudson, Chaddeston North. Councillor Kirk Corson, Alveston North.
Lovely, thank you. So we've got minutes held from the meeting on the 8th of July as attached. Are there any amendments, any changes, anything to note? Nothing from myself. It's going nice and smoothly so far. Let's go to item 4, which is the NHS 10-year plan, and that's Sean, I believe.
Yes, thank you. Just this is paper originally written for the meeting originally in September. There's a few additional updates that I can do at the end of the paper. Just going to pull out a few key points from the paper, if that's okay. So the 10-year plan was published by the government on the 3rd of July. And it's the government's mission to kind of put the NHS back onto a firm footing. Partly in response to the Darcy review which took place last year, which did a sort of an in-depth analysis of the state of the NHS under the new government as it came in during that year. The plan sets out quite a lot of detail. There's a summary attached to the paper, but there's a 140-page document, which is the full plan, and sets out a lot of areas of change, but specifically 3 what they call radical shifts, and that's around moving hospital care to community, move from analog to digital, move from sickness to prevention. So within the plan, there are significant number of policy commitments to improve access, to create a neighbourhood health service, to embrace the digital world for both care provision and to benefit the workforce and productivity and efficiency. And quite importantly, change the NHS from being a kind of sickness service that it's become to being an actual health service and trying to help people stay healthy. There's a significant part of the plan which is around reform, that describes a new operating model, which basically means that the centre gets smaller and power gets devolved out into communities, including power for patients, reshaping the workforce for the NHS to fit these new policy directions. We are waiting a significant amount of additional information to support the plan, so the delivery plan from NHS England, and also moving towards, rather than having annual allocation of finance, moving towards a 3-year allocation programme so we can plan further in advance to respond to annual pressure. Specifically, there's a programme of reform for the NHS, which the plan sets out. And as I said, it's trying to move from what's become a central governance model, if you like, and command and control to pushing more decision making out into local areas. That includes the NHS England and Department of Health coming together and reducing their headcount by 50% at the centre And also ICB's received instructions on the 13th of March asking us to make 50% cost reductions on our workforce. And I think the rhetoric there was around kind of having clarity on the roles of ICBs of regions of NHS England and the centre, and not duplicating that work. That's obviously been a fairly significant focus for ICB leaders over the last few months. It's been agreed that to make those reductions within ICBs, we can't do that on the footprints that we currently operate on. So there are 42 ICBs in England, and this concept of clustering of ICBs is the way in which we think we can make that work from a workforce point of view, and actually to be able to commission at a bigger scale. So Derby and Derbyshire ICB has been agreed will cluster with Nottingham and Nottinghamshire ICB and with Lincolnshire ICB. And the cluster word is important. That's not a merger as such. That will be subject to legislative change, but we do anticipate that coming. Probably not next year, the year after. And then there will be probably mergers of ICBs at that point. I think that currently the clustering process means that the ICB numbers will go from 42 to 26. So we'll go from 3, if you like, in our part of the world down to 1 cluster. The ICBs themselves will remain legal entities because they're set up in legislation. So we continue to have individual boards, but we will work as boards in common to change efficient. And we think in Derbyshire now, we need to make cost reduction around 45% to the workforce. But the paper highlights that Cathy McLean, who was the chair of Derby and Derbyshire ICB and Nottinghamshire ICB separately, she's been appointed as the cluster chair. And just to update from what's in the paper, we have appointed Amanda Sullivan as the chief executive of the cluster. Amanda was the chief executive of Nottinghamshire ICB. So that those of you who knew Chris Clayton, who was our chief executive in Derby, Derbyshire, is now left the ICB to work for NHS Wales. Amanda's taken over from normally from the 1st of October. Also, since the paper was written, appointed our executive team cluster. So that's colleagues who were executives in the existing organisations. They've been through a competitive process to be appointed, and we've also appointed our non-executive directors now. We're just in the process of announcing those names, along with a series of partner members for the boards who are made of our partners within the healthcare system, including local authority. Just hot off the press today, there's been a national, not been actually announced yet, but we are expecting an announcement this evening of the redundancy scheme that sits alongside those reductions from NHS England and from government. Significant negotiation with the Treasury about how it's funded, given the pressures already on the NHS finances. So we're expecting detail to come on that later this evening. Obviously, we'll be reviewing that and processing that over the coming days. So that's kind of the massive headlines on what was in the paper started. Just to quickly update, since the paper, we've also since had published what's called the medium-term planning framework. Framework seems to be the buzzword at present, and that was published in October, and that sets out the next steps to deliver the 10-year plan for the NHS. So that applies to ICBs and to NHS provider organisations and other, and highlights the sort of the performance targets that the NHS needs to deliver for the next 3 to 5 years. So to get another signal that we're trying to move to a longer term planning process than just an annual process. I think the ethos of that is it tries to bridge the gap in the current service provision and pressures that we see to a state where we're more stable and could start to move more positively into delivering the outcomes set out in the 10-year plan. So the more that and follow all of that, including kind of condition-related frameworks and things like that. So, but what we have got to do is to submit our 3-year activity and finance plans into February, and then develop a 5-year health improvement plan based on what's in the 10-year plan and what we think the local issues are, which we need to submit later in 2026. And I think just to flag that those processes will and important to bring the detail of that to the committee. I'm very conscious I'm talking in kind of policy terms here, but actually we need to get to the nitty-gritty of what it means. But we'll commit to bringing the full update on those. And we've also had the publication this month of what's called the Strategic Commissioning Framework, which sets out what ICBs are here to do for the future, which is a little bit less around performance management of the system, much more about understanding the local health needs and commissioning and shaping the kind of healthcare market, if you like, to make sure that we're commissioning services that have that kind of longer term view of health improvement. So the role of the ICB is much more about understanding what the population health data tells us about local issues and making sure we've got full sight on the health inequalities that exist. And the work we've already done to date around some of the community work that we do will kind of accelerate massively, I think, over the course of the next few years. So that was all I was planning to say, Chair, if that's okay. I'll try and take any questions.
Yeah, so it's a lengthy document, as you mentioned. There's a lot of within that. So I'm going to open it up to the floor initially to see if there are any councillor queries or anything that anybody wanted to raise specifically on the 10-year plan.
I've just got one question, Chair. So it's to do with the move from analogue to digital. I'm just curious to understand within sort of the 10-year plan timeframe, what sort of impact do we expect, if there is going to be an impact, of the use of AI within the National Health Service? Because, I mean, just from my perspective, the rate at which AI is developing is feels like a lightning speed at the moment. You know, I use ChatGPT all the time, and the rate at which it can now do things is quite scary. So I'm just wondering, are there any plans to try and incorporate AI into the 10-year plan, and what's that going to sort of look like? So, you know, what's the NHS going to look like in 2035? The use of artificial intelligence, etc.
There's a detailed section on in the full 10-year plan documents about AI, and I think there's like lots of different areas where that can be deployed. So I think from a administrative purpose, I think there's a signal in the support better to use technology that supports them to be more efficient in the way that we take notes from consultants, for example.
Okay.
But also, I think there's connected to that is the use of AI to help support things like appointment setting process, things like that. So it frees up the time for administrators and for clinicians, so that it becomes a much more efficient process. And I think the idea there is that frees up time to concentrate more time on care.
Yeah,
that's on the kind of administrative side. On the and I'm not an expert on the health technology, just I should say that, but I think there's a significant advances in healthcare technology. I think there's quite a lot of use already about the robotic surgery and things like that. But I think that the plan signals a rapid acceleration of that. Lots of examples in there of where health systems across the world are already deploying some of this technology. And I think that plan signals there's lots of stuff in there about how we can catch up that ability to use that technology and become the sort of, quite in the document, kind of the world leader on how we use that technology to support healthcare.
Yeah, it is quite a stark message, isn't it? In the executive summary, it says very clearly there, it's reform or die. Did you get the impression that all staff within NHS are up to this challenge? Or do you think there'll be any resistance to it because change is threatening to everybody, perhaps their own positions, perhaps their ways of working? Because it is very stark and it's laid out very clearly some of the ways that we need to be. I can remember speaking at the Health and Wellbeing Boards many years ago about needing to support more people in the community. And we never seem to really got round to it. And there's all seemed to be reasonable explanations for it, but somehow this suggests we're going to have to break through that, because simply waiting for things to change, that's not going to change it. Looking at page 10, talking about the 3 shifts that will help cure financial sustainability, but more care in the community is cheaper and more effective than care in hospitals. I would have always thought that was the case. Now, I did years ago. I just wonder why it's taken years to get to this point where it's all either do or die. What do you think the problems have been in trying to move towards more care in the community, where it's what people want and it seems to be cheaper?
I think, I mean, again, I can't speak on behalf of all the staff in NHS, but I think the broader document sets that reforms potentially, in previous reforms potentially incentivise kind of the hospital-based care model with the way in which finance and activity is set up. I think it's really clear that moving to that community neighbourhood model is the way we need to go. Not just because it's probably better for patients to be treated close to where they live, but also to free up the resources in hospital so they can concentrate on the more acute clinical needs. I think it's difficult to discuss the politics of it, but I think it is a thing around political reforms that have taken place that probably hampered some progress there. I think, interestingly, and in the fuller document, there is a case study of the integrated neighbourhood team in Derby. Which you might know as Team Up, and I think you've perhaps heard about that before. So it's really good to see that some of the local work we've done on Team Up, not just in Derby, but across the county, has been nationally recognised as kind of front running on some of those things. I don't know if the colleagues would want to.
So do you think it's a case of just doing more of what we've been starting to do, and at a greater pace?
I think absolutely that, but I think there's also the plan flags that there's other roles within the health system that we can make better use of. So the use of pharmacists, and dentists and opticians, and I don't just mean care they provide specifically directly now, but actually getting them much more involved in that overall kind of neighbourhood health assessment of someone's care. So I think the other thing to flag is that there's a big section in there, in the digital section and prevention sections around genomics, which I don't, again, I'm not no expert on that, but actually being able to get much more detailed information about the different factors that are in us as individuals from a young age, actually trying to set up locally that we can understand those and capture people before they become patients, if you like, to make sure that we can predict a bit more about what their future health needs will be. So it's very ambitious, and it does sound like a big shift. I think, going back to the original point about the staff, I think there is a significant cultural change that we need to make, and power staff to understand and embrace this. I think, I can't speak for everybody, but I think that making hospital-based care much more efficient is something that patients or staff. Colleagues want to
I was just going to let B come in, and then I'll go to the Councillor Ashby and then Councillor Hudson.
Happy to pick up the point around community and doing more in the community. I think Derby Wellbeing is a good example of that already. For the health, for example, which we will talk about in a moment. The neighbourhood teamwork that has been done both in Derbyshire is a really good example of more work that we are already doing in the community with particularly older people and supporting people in their own communities as well. So we will see a further shift of that. To be able to deal with demands that we are seeing in the hospital, we're going to have to be more resilient in the communities as well. So, and for mental health, the future plan, the 10-year plan, is talking about 24/7 mental health teams as well, which is something that we will be working together as a partnership as well to deliver even more services out in the community with mental health problems as well.
There are basic things, aren't there? I mean, again, for years, we talked about pharmacists doing one. And it's now, when I went in to buy something at Boots, they said, would you like to have your blood test, your blood pressure taken? Yeah. And all sorts of good advice came from that, which could have prevented further things for me down the line. And so hopefully we'll continue to see more of that and get our colleagues in pharmacy introduced to that way of working. But there's a hell of a lot to actually be done, and I think when you start where there's the will, hopefully we'll find the way.
And it's quite exciting, I think, for staff as well to do things differently. We'll probably hear from that in the presentation a bit later on as well. So I would say that the change is needed, but I think people will embrace it as well, I think.
But one of the difficulties I've never got my head around about having to go to Central Hospital, where it's a pain to get there, it's a pain to park up, to wait, where you should be able to go to your doctor. Why can't the GPs take the blood tests as they used to do? You know, I mean, there are simple things, like, again, about care in the community, basic things like that. Shouldn't be relied on to people traipsing a number of miles to hospitals and sitting in a queue, blocking the corridors up where there's other people lying in trolleys. It just seems a nonsense.
And there's equal developments on diagnostic centres as well in communities that are going to be rolled out. So that will make a really...
So it's a lived experience, isn't it, of our communities that we as councillors pick up, and I'm sure you must do as well. You're saying, well, God, there's going to be a better way of doing this, which is more efficient, more effective, what people want. Okay, thank you.
Thank you, Councillor Repton. Just to pick up on a few points that were made there, I think you mentioned about AI and digital technologies moving forward, and I've had the privilege of being involved in the NHS a little bit in the last month in terms of being hospitalised and things for various things. I've had into various walk-in centres, and I've seen some significant changes already where they've got the digital boards when you walk in that do the assessments and things like that, which are a real improvement. I think one of the things that's been highlighted in what Councillor Repton's saying is around access to GPs. It's all well and good saying we need to get the community GPs more accessible, but how are we going to do that? For me, we don't have the number of GPs in communities that we've perhaps had historically. It's almost like we're going back to where we used to be in the 80s and 90s when I was a young person, and you spent, if you needed to see a doctor, you saw your local doctor who knew you. And I appreciate that we've got to this, we're trying to get back to where we were in some state. But my concern is there are areas that are closing GP practices. I think, if I remember correctly, Oakwood's had a recent closure of a GP practice. And that is for Derby people on the ground. We're saying, you know, this is going to be the new system. We're going to have more community-based object. But then we're seeing GP services closing because they don't presumably have the GPs to keep them going. So there's concern there. You've mentioned Pharmacy First being absolutely brilliant, a new step forward. And I've, again, witnessed that myself and seen lots of people using that as a real stop sort of first call before GPs. But I think if we're talking about on the ground, how's it going to impact us? This need for more GPs is something that we, you know, that's got to be the first port of call for the NHS in general. And I know we don't necessarily have all the answers for that right now, but I'm going to go to Councillor Ashby and then Councillor Hudson, followed by Councillor Lonsdale.
Thank you. Thank you very much, John. Really good to talk about this actually, and to read more about it, get more. Only read the summary, and I'm sure there's an awful lot more detail in the full document, but I don't have to read those anymore. And I resist answering some of the questions that you'll be able to answer better than me, because some of these I can think of answers to, because Pharmacy First has been on and off for quite a few years, as we know, because it's comes on, you know, comes when it's being funded, and then the funding stops, and then it dies, and then it comes back again, and it's slightly improved. I could ask a ton of questions. I suppose one of the things I'd really like to know, because some of us have, you know, I can remember when I first came to England to start my nurse training in the mid-70s, there was a big NHS reorganisation. That was 75. And I can't remember how many NHS reorganisations there have been in my time in the NHS since 1975. Too many. Certainly about the last 3 have been about, you know, when I was at the CCD and working with you, Sean, they've been about trying to get that shift, and the reorganisations before CCD from PCT. What that was called before that.
PCGs.
No, before PCGs and PCTs, there was something else.
Health authority.
No, but there was something putting funding into general practice to get more funding into fund holding. That's the one I wanted. Thank you. But they were all about getting funds out and care out of secondary care and into primary care. And here we are still trying to do the same thing. So I suppose my really good question, John, is, and it feels to me like ICBs haven't been around long, and now they're being reorganised. And on the one hand, you're saying you're forming a cluster, but Derby and Derbyshire will still have its own ICB, but yet you've got to cut staff by 45% or budgets by 45%, which is the same thing, or 45 or 50%. So I suppose what I'd really like to know is, do you really think it's going to work this time? Is the shift out of secondary care into primary care going to be possible? Because we know that part of the reason it's never been possible, I would say to Martin and others, is because the consultants are primarily in hospital and everything in hospital costs more. So that's where most of the funding's gone. And if you pull it out, then you're making your own local hospitals go bust. And it's really complex and it's really difficult. So is it going to be possible? And how do you guys, who are at the centre of all this latest shifting around, how do you really feel about it? And do you think it's really going to work? If that's not a terribly unfair question.
I think I've been in the NHS for 21 years. I think I've worked out this since my 8th reform in that time.
Proves the point beautifully.
And I suppose trying to be politically diplomatic, I suppose we're always at the under the political movement of the time, and obviously different governments, different politicians have got their different views on how things need to work. But I can only speak for myself, and I'm just about to go through another reorganisation. But I suppose I still, actually reading the 10-year plan, sometimes these documents are boring. Say that, is that
Absolutely.
it's actually, if we could deliver this, then it's quite exciting, as Bea said. And actually, there's a lot of necessary stuff to do, because we know that satisfaction in the NHS is at an all-time low. But that's not to take away from the absolutely massive hard work that staff, in frontline services deliver every day. So I don't work in a frontline organisation, but if we can do things that can support them, support the population to be healthier, and I'm not going to argue with that, and I want to carry on trying to do that. So that's my personal view. It is, I suppose, slightly frustrating that we have to focus on reform rather than focus on improvement. But that's, so I can't really answer the question about whether it will work. But it needs to be given time, and I think moves towards longer term planning rounds and longer term financial allocation does signal that there's a sort of shift to allowing that space and time to get things actually implemented. 10-year plan, so a lot of this is which I think the government spells out in the document. But I'm excited by it. I can't say on behalf of anybody else that they are.
Yeah, I mean, I remember the excitement when the first 10-year plan came out in 2000, I think it was, and that really also was hugely helpful in being able to plan, and actually did make significant changes.
Yes.
So yeah, I mean, I felt there is a lot of exciting stuff. I just wondered whether you feel. I mean, I have loads of sort of gritty questions. I fear there's mention in the document, page 7 or 8, about high autonomy, and I fear that I would ask whether there isn't a risk of fragmentation of the NHS if that happens. I do wonder about the evidence base for these IHOS, those, can't even know what they stand for.
Integrated health
organisation, yeah. I do wonder about evidence based, rushing ahead and doing things without waiting to check that they're actually working. So I don't know about the evidence base, but it's working. And I'm very concerned when I read about risks of money being wasted on bonuses and creating a kind of a bonus culture. that rings big alarm bells for me. And I do wonder about, there's talk in here about private providers providing quite a lot of care, which I fully understand, and I know that had to happen back in 2000, and I know how low morale was in the NHS in the 90s until after 97. I hope it's not as low, but I fear it's even more now. But I just wonder how can there be adequate investment in the NHS when private providers are really having to be paid to clear backlogs and do the catch up. So yeah, those are a few of my questions. On supplies. Bees, why cancer care isn't mentioned? That's a huge area that we're lagging behind areas of Europe. But I hope that's simply that they couldn't mention everything because it's only out somewhere. I did wonder what wearables are. Making wearables standard.
Devices to be wear to.
Yeah, sorry, but couldn't they say that? I know. I can Google wearables, but wearables will mean different things in different contexts.
We don't naming any names.
What you know,
Yes.
there's a lot in there. I think my reading of the thing around kind of incentivization of providers to do well, I sort of flip it and I hope that that's set up in a way that doesn't unfairly penalise providers who are in the document sets that all the way through that often what's termed poorest carers in the areas of more inequality.
Yeah.
So it would be unfortunate, wouldn't it, if those organisations that operate in those areas are penalised when they're probably starting from the position of having the most to do. So it needs to be balanced properly. But I think a lot of it is a lot of the answers to your question is probably the same as like the puddings in the eating. We need to see a bit more detail about how this is intended to be taken forward. But it does signal a kind of a move back towards the kind of freedoms that foundation trusts originally had when they were established, and the foundation trust model seems like it's fully back on the table and trying to get back to those worlds where if you perform well, you get freedom and create surpluses to invest and all those sorts of things. So it does feel a little bit like we've seen some of it before. But like I say, I think it just needs to get that traction and be given the time to bed in and work and settle. Or else we'll just be in another reform in 18 months' time when it's not been given the chance to succeed. But so that doesn't pick out all the points you make. I think there's a similar answer for some of them. So trying to avoid being too political.
Just, I mean, I hope it works.
Yeah.
We'll all be delighted if we can sit here 2 or 3 years' time. It's easier to get a GP appointment or to have stuff done locally. And if everybody's breathing easier and enjoying their jobs in the NHS, I mean, I fully understand saying throwing more money isn't necessarily the answer. But actually, we're going to continue to bleed our best newly qualified doctors and nurses to Australia and New Zealand, where they have a better quality of life, are better respected and better paid if we don't actually also have their sons. But
and I'm not sure.
You can't change that either.
I'm not sure if it's in the summary or if it's in the full document, but it just talks kind of the flip side of that as well as talking about reducing international recruitment into the NHS, which
that'd be fine if you're the people on the ground.
Exactly. We've recruited internationally like some of the best surgeons in the world. So like I want to put a stop to some of that. I'm not so sure, but we have to be careful not to have both situations happen.
Councillor Hudson.
Right. I'm just going to give a total links into what everybody else has said. I'm going to give some observation, then I'm going to ask a question. As councillors, we all sit on various boards. We see countless forward plans across a variety of things. Very, very similar documents to this, not the same subject. When it comes to implementing it, the stumbling block across pretty much everything, when you're creating new job roles or trying to switch people between different job roles, it always then involves recruitment. Now, when it comes down to trying to find people for the right job roles and recruiting, because even if you're going to advertise, you already know there's no guarantee you're going to get some. That's where it actually sort of hits a stumbling block. Is it actually factored into any forward plan that the recruitment and the switching of roles is where it's actually going to could potentially come apart?
I think it's a really good point. I mean, again, the summary, I think it's page 8, the summary talks about the workforce requirements. And this isn't just about, putting a job out tomorrow and getting staff in a month's time, whatever. There's a whole process of, working with the universities and the deaneries and all those sorts of things to make sure we are setting up the courses that are required to train the right staff for the future. So, I mean, again, it's going to take time to do that and bed that in, isn't it? But building on work that already exists, I suppose. But that's not going to be something that can happen overnight because we perhaps haven't got the right training for the right roles that we're going to need for the future. So I think it's a good point around that workforce model being vital to delivering the future.
We could be having those conversations now. Then in a couple of years, a new plan comes in, and just as those people have found themselves qualified to do what was in the previous plan, it then suddenly changes. It's not just in this sector, it happens across the board.
And it goes back to the point I think about, we've got to give this time to have traction and bed in and not change the direction too quickly away from it. That's what you say will come to bear, won't you?
And I think a positive part in this round is actually the multiple opportunity for multiple year planning, I think, which is probably the best one I've seen in my 34 years in NHS. So hopefully, and again, it's with hope that will help as well in retaining people and keeping people in service feeling one ahead. But that will form a big part of the workforce plan.
It's an interesting point that you make, Councillor Hudson, because I was at Remembrance service on Sunday, and sat next to somebody I hadn't seen for a few years, a young person who'd been through a school, and she was now 18, and she's currently doing the SEH or the what's it called, where they're helping the nurses within hospitals. HCAs, that's the one I was looking for. Healthcare. And just in general conversation, she was saying she's hoping to do a nursing, but the place where she's working within the hospital is saying no, she doesn't. They can't train her at the moment because they don't have the numbers of HCAs that they need, but then in the counter, we've not got ingrown NHS nurses. So is part of within this 10-year plan, where are we at in terms of sort of giving people those chances that are currently in those types of roles to become fully fledged nurses?
I mean, I'm a nurse by background, but we do, I don't know where that person works at the minute. But if there are opportunities, we do try and grow our own. Because obviously, if somebody comes in a healthcare assistant, there's various opportunities if they want to do the associate role. So in Ulster, that would be the state enrollment nurse. So I've been around quite a long time as well. And then obviously there's a route into registered nursing, as there is for other role types as well. Because I think, to your point, I think we have to look at other workforce types that can support, say, the medical workforce, which we have done around both clinical practitioners. I don't know where they work. But certainly within our trust, we have supported. But again, it very much depends on the money that's available to support them to go on, do that training for would be up to 3 years. Yes.
Yeah, I think it's one of those, isn't it, that I may be imagining this sort of within my old brain, but I remember a time when nursing qualifications in terms of going to uni or doing that sort of thing were better funded from the government. There was a drive to do that, wasn't there? At some stage, a bursary to do that. Are those still in place? Is there something that you, as a trust, we could be sort of, or as a council in general, be sort of advocating to bring that back into?
I mean, well, we have supported people to go through it. They get seconded on what they're currently paid at, which is usually in a band 2 or 3 where they come from. But to say we've not got any particular route going through at the minute. We'd normally go through the academic kind of university route and then partly fund you know, the degree themselves. I'm not absolutely in tune with the annual tuition fees and things like that. But there's a risk there because obviously they come out of 3-year training and they've got a huge debt. You know, I was looking
Absolutely, that's what puts people off, isn't it?
I was salaried right from being 18, but that was many years ago now. Yeah, and that gave us many, that kind of gets us to do it, you know.
But it does put people off to go to that next level, and I just think from a point of view of, you know, trying to recruit internally or trying to give that opportunity, that it's something that we should encourage from the government, NHS or the universities, especially for here in Derby.
There is. I looked this up today actually, Councillor Wilson, and Derby University does run the nurse apprenticeship programme. Both in Derby and Chesterfield. So the programme will run if there are sufficient people to do it. And
that brings me back
to apprenticeship training is what you were saying, which is a bit more of a mix and match from the historic.
Absolutely, but there's also the apprentices levy that a lot of trusts, I'm not sure if they're anything like the council, haven't necessarily utilised all of that apprenticeship levy funding. I don't know if anybody has any of that information around this table. But it would be useful to understand, because I know that as a council in the past we struggled to identify using those apprentices levy funds that were put together, because ultimately getting people to have one day out of a busy work and the impact that has on the other team members, the uptake was less. So I just wonder if the levy is there to support. Yeah, that'd be really interesting to see where that is in terms of Chess Derby. Councillor Hudson.
I'll just chime in when we're talking about tuition. It isn't a debt. It doesn't show up on anybody's credit reference. It does not affect a mortgage application. It's a 9% tax on earnings above £25,000 and above. That's all it is. It is dangerous language to call it a debt when it's not.
Depending on your lived experience of that.
I've got a degree and 2 masters, and I'm happy to pay a 9% tax on my earnings above £25,000. Yeah.
But the majority of people would automatically, once they're employed, be over that threshold, and that is a 9% tax on top of your 20%. Well,
yeah, it's also called.
And it does.
It's different alone.
I just don't like off our topic.
Yeah. Probably a difficult one to get into, that one. I think we all have a different view, perhaps. Moving on.
Emmy's got questions.
Yes, Councillor Lonsdale.
Thank you. Yeah, Councillor Ashby touched on it a little bit in her question, but she's coming at it from a different perspective. What I wanted to know was about Derby's a unique city. We've got a wonderful population. We've got a great deal of things that are not in with our health challenges, like London. Is this enough? Is this a bit one size fits all, or is there enough flexibility in it to genuinely get down deep into the issues that are unique to Derby and be able to take things that are good from other places, but also develop our own solutions to meet our needs here?
Yeah, thank you. I think there's a couple of things both to say. I'll probably forget the second one, I get the first one. But the first thing to say is that I mentioned the strategic commissioning framework which came out a couple of weeks ago. That's very clear that we need to be understanding the kind of granularity of health inequalities across our commissioning area. There's a risk there that if we go to a cluster footprint, it actually may lose some locality focus. But I think actually the second point, which I haven't forgotten, was I think that back to the neighbourhood health service issue, building on the work we've already done in local place alliances, really trying to understand what it is that's happening in communities, trying to put the right services in place. And I think the plan overall seems to give permission that can be different across different areas. But exactly as you say, I think it's really important that we try not to reinvent wheels where things have been successful elsewhere that we could try and adopt, but also not to use those just to replace the way that we know things can work in our localities already. I think the work of team, for example, I mentioned before, it's about getting to know the people. That's really important for those services to work and understand who it is that we're trying to help and support. So I think there are risks with it. I think the geographical risk applies, but I think actually the neighbourhood health, if we can deliver that, we can kind of mitigate the risk of losing sight of that sort of local touch. Again, it's proof of the pudding is in the eating, but
Thinking about it and we're
absolutely right.
Good. Excellent. Thank you.
So, are there any other questions from our councillor colleagues? Just, and we touched on it historically in terms of the differentiation between ages of being able to use technology and ICT and AI and all that information. And I find as I'm getting older, I struggle more than I ever did when I was younger. And you think you've developed more as you get older, but it's so my concern is with all the change in things, obviously we all get used to it, and I've seen some really positive things, booking appointments online, big recent change from my doctors and things like that, which is all great. But the impact on those that don't have access to that, whether that's financially, they don't have the internet, or they don't have access to technology in general, or their age or abilities mean that they're restricted in being able to do that. How are we, as a community-based, helping to make sure that we're not missing or falling into dark holes?
I think it's really important. And again, plan, I think it's in the summary, but it's certainly in the broader document, talks about this whole, the expansion of the NHS app, where pretty much everyone's first interaction with the health service, whether it's trying to book an appointment or get advice or whatever, will be through the app. And when I'm reading that, I'm thinking the same thing that you're thinking about. Actually, that's great if you can use an app.
Yeah, it's great.
Thinking of my mum, who's only just recently got a smartphone, and she struggles to use it for text messaging, let alone anything else. But again, the plan does signal we have got support in place in Derby and Derbyshire with the community organisations to actually help. They put on sessions where people can get help to use the app and other health technology. And the plan does signal that we need to kind of expand that, make sure that continues to be available for people. But and I think again the plan does also say that the traditional ways of doing things might not necessarily disappear. But then I'd start to think about, okay, well, how do you do both? How do you double run that? And is that efficient? But so it does recognise that in the plan. But it's all about how does that get delivered? Can we make sure we can support people, not leave people behind them? And by advancing the technology for, perhaps the majority, we don't leave behind the minority that can't use it and creating bigger health inequality. So
my initial concern is, for example, booking online. So many appointments to book online, and majority of them being online. And then there's those telephone calls that we all know where we're on hold for, you are caller number 476. Slight exaggeration, but I've definitely been in the 30s before now when I've called up on a Monday morning. But that the appointments wise, they're just not going to be able to facilitate the people calling, let alone prioritising. So I get this need for the online system to give you that initial, what is your issue? Can you go here first? Can you go here first? That is great, but there still needs to be that ability to be disabled, short, partially sighted, all the sort of things that we know are going to struggle to do that, and that is just a big concern for me personally, Councillor Ashby.
Just one question flipping back, not so much on that, but I completely agree with you on that. I don't know how, it'd be interesting to see how that's paid for and these people are paid for. You said earlier, Sean, that ICBs won't be doing performance management. So who will?
Well, we'll ICBs will still kind of manage contracts with provider organisation. but the kind of boundary's been defined now that if where providers aren't performing to the required standards, the NHS England will take over that responsibility.
I just wondered who's going to
I
perform
think
this
at the minute, and I'm sure Lee will probably say this more than I would, but at the minute you've got ICBs trying to do it, you've got NHS England trying to do it, and you've also got the centre trying to do it. So providers are getting always managed to death by multiple organisations, and this aims to try and line that out.
That in general is a positive. If we can put the funding into the services on the ground rather than into the, then naturally those things will improve anyway. So it's that catch-22, isn't it? Chicken and egg. Unless there's any other questions, I think one of the last sort of one that I highlighted really was around the document picks up page 4, just around neighbourhood health centres opening for 12 hours a day, 6 days a week. And that's, you know, we've talked about NHS England being 24/7 and all the rest of it. But we know that isn't always achievable, especially in you know, Spondon has only just realised that we can open shops on a Wednesday. You know, we're still in a different era, and it's trying to encourage people to do that, but people don't necessarily want the shift patterns. They want the 9 till 5s. They want the times with their kids. It's all well and good saying it on paper, but how is that going to actually come into fruition on the ground? Because a lot of the people that we currently have will have contracts, and the unions will not be happy if we start changing to shift patterns, etc. And it's just interesting for me as to how that's going to happen.
I think that's pencil in for a future discussion. It's a great question again, and it's goes back to the workforce plan. Exactly the thing you just described, and I suppose what we can't have is a lot of empty buildings that have got staff there that haven't got patients in them because they don't understand the demand patterns and things. But I think again, devil's in the detail about how that will work, what the investment will be to support that from a capital point of view. I know that again the plan talks about utilising existing estate for those things, but estates are a bit of a premium as things stand. So we'll need to see further guidance on it, I think, before we can say how that will work. But I mean, I suppose the other thing to say is we are making progress in terms of how we think the neighbourhood health care system needs to be set up and established. There's quite a lot of consensus about that, but the model of moving care from hospital to community, if you like, is everyone's behind that, I think. But so in terms of actually creating buildings with staff in them and services being delivered, that's another thing altogether, I think. So,
sorry, can I just jump in? Was your question more about workforce and how we get the workforce to move to more flexible working?
Yeah.
I think from our perspective, what we're seeing is a workforce that wants to work more flexibly. Yeah. So working compressed hours, shorter weeks. So we already have that kind of move towards that way of working. So I think shifting that to say 6-day working, people can work those compressed hours and have more work-life balance. I think that's what our workforce wants.
Brilliant. And that's the sort of question, really. That's the positive element to this, as you say, that working 4 days and having 3 days off would all love. I would love to do that personally, but you know, it's and the compressed hours or flexible working in general, because we've all got very complicated lives nowadays. It's
9 to 5, Monday to Friday is quite inhibiting for that. So
absolutely.
Elongating of hours, shifts over
start at 8:30 and finish at 3, and nothing's all joined up at the moment, is it? So. Okay, thank you.
There's people used to well, you know, because a lot to start off in hospitals, so they're much more flexible. Yeah. But there's already extended hours in general practice. So it's going to talk. So
there has a little bit, but if you think about, if you think about the number of people that are working from shift pattern is an 8 to 9, 8 in the morning till 8 at night, and there still isn't that accessibility as it is, you know. So it's so Councillor Cuss, so.
Yeah, sorry, just a quick one. Where it says publish individual understanding league table starting this summer, is that the NHS Acute Trust league table? Is that what it's referring to? So my question is is towards the board. Is it worth put it onto the at a later stage a programme to look at where Derby Hospital is in the league and analyse that data and see what we're doing, what the hospital is doing to try and progress and get higher up the table. That's the question to the board, really.
Yeah, and that brings me on to my next point, really, is it's great to see the 10-year plan, but we need to sort of review this on an annual basis, you know, see where we are in 12 months, see where we are in 24 months, and hopefully we start to see a lot of this is happening. And as you say, as part of that annual review within this board, we can look at where they are on those league tables at the same time and see where we are struggling. So at the moment, it's that sort of, this is the starting point, isn't it? We've got concerns and reasons of things that we are seeing that could be stumbling blocks, but until we start to give it time. Yeah, absolutely, let's bring it back in 12 months time. With that, I don't want to bring it back in 3 months time or 6 months time, or let's give them a year at least to start. Yes, sorry.
The next milestone, Chef, is okay, is that we've got, it's our 5-year population health strategy. I think it's by the end of this financial year. So I think that might be a milestone to actually, what's the local response to this? What we're saying we need to do about these things. And that'll also include all the activity and finance data and workforce data that will support that 3-year kind of move. So we could perhaps work behind the scenes to bring that back. I think it's important for this committee to see that, the board to see it.
Yeah, I think it's going to come in January, or somebody's going to the all councillor meeting around, I think it's like a 6 PM Teams meeting to go through how the 10-year plan is being implemented on a local level.
Yeah,
I think scheduled to come to the next January one. I think so.
And that would be useful. But again, I think it's great that we're doing that. But for me, there's more merit in looking at this a bit further down the line. We need to give a little bit of time for these things to start to come into fruition and not be pulling you out and doing more bureaucracy of things and saying, let's have another report on this tiny little bit right now. But so let's, if you're happy with that, team. Yeah. So yeah, we'll do that. Thank you very much for the report and answering as many questions as we can, because we appreciate we can't answer all the questions right now. Thank you. Any other points? Then we're moving on to item 6, which is our living well, improving mental health services. We've got a few people to give us this update, so I'll let the floor take it as they see fit.
Thank you, Chair, for introducing us, and thank you for letting us come and talk about this exciting development. I'm just going to do an introduction and I'll let Holly speak about the model on the ground, really. Just wanted to see a little bit on living well, which is for Derby Wellbeing in Derby as well, in terms of a bit of a different public health service that was very similar to living well. So Derby Wellbeing is the programme in Derby. This goes back to the long-term plan which preceded the 10-year plan. So in 2019-2020, we were allocated additional funding for expanding community mental health teams, and they've got various levels of interventions that are being expanded on that community offer. And Living Well is one part of it, and it really is looking through improving access to mental health services, but more on the employment support with personalised care and support, and actually getting people more active in communities as well. So more the enablement side of things, really. It really focuses on recovery, and you'll probably see some of those stories coming out in the feedback we've had from people with lived experience who've gone through the services as well. I have to point out as well that from the start it was co-produced with our lived experience and people with mental health problems who have helped support the 4-5-year journey that we've been on with the programme as well, to really make sure it's actually baked in and embedded in what is needed for our local population. And when we talk about multidisciplinary team or multi-agency working, we really truly mean that. So we're working in partnership with voluntary sector partners, all of the health services, local authority colleagues, really working well together. That's probably where I'll stop my introduction and pass things on. It's calm, isn't it? Like,
I wasn't keeping up. So really talking about how we produce the model. So like you said, it's been co-produced throughout the inception, design, planning, and ongoing implementation delivery. It's been ensuring that voice of lived experience is kind of embedded throughout everything we do. So we originally started, the ICB commissioned an organisation called the Innovation Unit that supported us as a critical friend and an objective party in bringing all different stakeholders in this together and being able to talk through some of the tensions of organisational barriers, breaking away from siloed working, being able to kind of work more collaboratively together, and devising that vision, purpose, getting feedback all the way through from people from lived experience to make sure their voice is heard and is embedded through what we're designing. And one of our starting points was coming together and thinking about, well, what is Derby? What is the identity of Derby? What is our local population? What are our strengths, our assets in the community? How do we capitalise on those in order to create a service that's serving the needs of our community, and also making sure that we're engaging community members to do that as well. We kind of had to almost humble ourselves as statutory organisations and understand that, you know, we're not getting it right. We're not meeting things. There's a big gap between primary and secondary services that people are falling through, and looking at addressing that and devolving some of that power to voluntary sector organisations, community organisations, to our residents and communities, and realising that actually that's where the real essence and assets are, how we sustain this model. Again, creating those equity relationships, I think, is fundamental part of that, working through some of the tensions. We still have tensions because we will have bureaucratic processes, particularly within local authority and NHS, and we have to work through those tensions. But it is an iterative process, and I think that's what we accept, that this is an evolving model, still in the transformation phase. We have ongoing dialogues about how things work, and I think it's that part of the 10-year plan will be this, being brave enough to change things and do things very differently, and also not be scared to get things wrong and then have to change them and be able to do that. I think that's a scary thing for statutory organisations, but you almost have to take that leap of faith and devolve some of that power again to communities. So in terms of the vision, this is what was created in terms of how we want services to operate. It aligns to person-centred thinking and looks at people's assets and communities rather than services being at the centre of that and health-focused model. It looks at where people are in their lives, what's important to them, so it focuses on the centre about people's neighbours, colleagues, families and friends being the fundamental part of their support network, and statutory services being on the periphery of that. Again, it doesn't centre on how the individual fits into services. It's about how we can fit around that individual. And it's really important that we engage other partner agencies and community organisations. So whether it's someone, sports centre, faith groups, you know, shops, restaurants, whether someone frequents to the local pub, how are we engaging with those other community organisations to make more enabling and more mental health friendly. So there's some things through public health we're doing, like mental health first aider courses. We have the local area coordinators that are fundamental to part of this as well. And they were in my portfolio at one time, but they kind of do a broader role now. So engaging in that locality working has been fundamental to moving to this. So there's multiple layers. We're working with grassroots organisations, making sure we engage different communities, and all those, also those underserved communities, making sure we are accessible to those people as well, and our services for purpose. And as you see, that wedge, which is the Living Well team, the dog wellbeing team, cuts across all of those, and the idea is for them to connect on all of those layers and people's support networks, what's available, making sure we link in with PCNs and housing as well. And also we're sitting on the outside in terms of what we can offer more specialist interventions as well, but making sure those add to the person's life and not kind of dictate and drive that, which I think is a place we've come from previously. Again, still in the transformation phase. We have other parts of the models, and you'll probably hear in a bit about collaboratives and how we work in that space as well with wider community organisations and make sure everybody is engaged in this way of working. And also, I think it's important to note that this is in line with what you hear in the 10-year plan around being preventative, making sure that it's co-produced, working in an integrated way, and also making sure that we're focused on individuals and planning with individuals and not just kind of reacting and staying in our siloed ways of working. And I think the positive thing is we hear from other neighbouring ICBs about our model as well, and have been talks and on our partners, which is quite interested in the way we're doing things and looking at adopting some of that. So it is something that is taking a lot of time, effort and energy, but I feel it's the right vision and the right kind of move towards that future of mental health and moving away from those traditional services and being more focused on individuals. So I will hand over to
It's me next, isn't it? I just wanted to mention that when we me and Cam have been there from the offset with this, I think but when we started it for the innovation unit, we started in High Peak and Derby City followed on. We thought that one side would fit all. We learned very quickly that that wasn't the case. So it's very unique to the area and how the structure sat really. But the model there is really, Cam mentioned prevention. It's there to offer that early access for up to 12 weeks. And the support can come. I won't say that we're trying to avoid the NHS badge because more often it might come from you, in terms of our BCSE colleagues, social care. We mentioned housing, employment support, etc. But they've also got that access to mental health as well. And that structure's worked really well. I'd say from the offset, we're all excited, but getting our partners, getting the three of us in a room, it wasn't quite, worked through, didn't when we got there. Which was brilliant. We've got the launch across. So BB mentioned, I think we're 5 years now down the journey. I think we always said when we started it that it would take us probably around 5 years to get to the point where it was working really well. But there's always that opportunity for looking at things and transforming it basically. The makeup really of the service, we've got peer support workers, wellbeing coaches, we've got social care practitioners, within health we've still got access to therapists and community psychiatric nurses. Bea mentioned that when we got to Derby it wasn't going to be Living Well, but we've got a Live Well strategy in Derby, so that's why we've got the slide named into Derby here. We have data. So in terms of where we're at with the transformation is that we've seen a steady increase in referrals, which is absolutely brilliant. When people are introduced to the service, they get a welcome call. So we're able to see that very early on. Invest is going to meet that person's need. It's supported around some of our plans around access, around, we call it 2+ contacts, community mental health. We have seen, obviously, as people have got better, we do discharge them. The idea is that if they need support, come very quickly back in. That is really important. And what you'll see there, one of the charts illustrates we've seen a decline in people accessing reactive measures such as going to A&E. That's absolutely not what we want. Obviously, people do need A&E, they need it, but we just want people to go on and want them to access support. We've been doing lots of work around, we mentioned BCSE, social care and health, but doing lots of work around primary care. And we're trying now to have that self-reintroduction so people can just, fall and come back in themselves. I think over the last 5 years, we've done lots of engagement with our comms and engagement colleagues, working at primary care network level as well, recognising that population health varies even within Derby City. There's quite a lot of variation really. And yeah, I guess with the, I guess this comes back to commissioning, but it's from a provider perspective, and I'm sure Cam and Snita will back me up on this, but having that longer planning cycle in terms of the contracts would certainly help. It sort of give the certainty, because the teams, we've managed to keep people, which is really good. And we've got slide 8 now.
So yes, it's important to obviously mention that us as VCSE, we've been providing the VCSE element of support since 1st of December 2024. So we've not, our organisation hasn't been here throughout the whole transformation, so we have come in last year. And the aim of ourselves are to work alongside NHS and health and social care to see how we can provide that community support through our wellbeing coaches and peer support. It's not just supporting them in the community, but it's also having a look at how we can link them in to any other community support that may be out there. So that's just a bit of background as to where we are in this journey. So still fairly new. So we have wellbeing coaches who give that one-to-one support, and it's very goal-based, focused, and just to see what it is that people want to do. How can they become more independent without relying so much on the other partners? So see where that goes. And it is very much encouraging. It's almost like working with them to achieve their goals, and it's a 12-week plan usually. We never really hold our patients to 12 weeks. It is based on needs really more than anything. And if we assess that they need a longer period, that's exactly what we'll be doing with support of our partners, of course. And then you have the peer support workers who have a very unique play in this, I would say. So they bring their lived experience of mental health and encourage the patients that they're working with to actually get out there and be more independent. So sometimes that can look like they go out with clinicians just to provide that encouragement, provide that voice. They've been there, and I think, who else best to actually to encourage these people. So that's that. We've got a bit of a journey here for Stacey. So as you can tell, it talks about her journey from the very get-go. She's obviously been diagnosed with some mental health conditions. If you look at it, so she's got PTSD. And as the journey's progressed, she's been given further diagnosis. So she came into the system, Derby Living Well, to be precise, 2020. And that's where she's had support with the partners and a peer support, a mentor. And as you can see from where she was from the beginning to where she's ended up, with that support, she's now one of the wellbeing coaches. So she's now using her lived experience to provide support to other patients. You've got a few quotes there from a wellbeing coach and a peer worker. Let you guys read that. So that's that. And then we've got a few statistics here. So as you can see, there's been 9.2k referrals to Living Well in the last 12 months. End of March 25. 170 people reintroduced themselves to the Living Well service. You got 180k contacts face-to-face, 26k contacts helped on the phone, 2.3k contacts helped on a video call. Could I
just chirp in here for the benefit of the group? This isn't just Derby City, is it? This is a combination of all areas, I presume.
Combination,
Yes, it's a combination, yeah.
That's what I'm just
Yeah.
checking.
Yes,
But for you know, because obviously this is the whole of Derbyshire.
it is living. Yes.
And that's sort of the questions for us would probably be based more around Derby City and which these numbers are Derby City, which areas we see of Derby City. And at this moment, I presume it's not broken down specifically.
It's not. No,
Okay, thank you. Just wanted to clarify that I wasn't wrong in that.
that's okay.
Understand.
So yes, that is the living well statistics. There.
I just also mentioned that we've also still got, I should have mentioned it when I was on, we've still got access to what we call the long-term offers to the end of illness. Because obviously people do need that support. The Living Well offer or Derby Wellbeing is open to the SMI cohort as well, and people do access it well, and they stay well. So just wanted to make that point, but you'll see on the slide that you've just obviously that we've seen a 16% reduction in long-term caseload because obviously we're managing people better because they've been getting that support. They need it.
So over to you now, Lee.
Is it back to me?
Yeah.
Okay. The next few slides, I'm not really going to go through them, but again, if you just want to take a couple of minutes to kind of read through. But what is kids that we do obviously get that got to think back on the service unit. It's not just the number that we use. And we'll continue to do that as a cycle really in terms of people accessing the service.
That's embedded into the way people work, into the paperwork. It's getting that constant feed, positive note to what's been the benefit, what's not going to go well. So that continues. There's a learning that. Yeah. So we get together, look at the any themes that are emerging from different partners involved. And to actually think about how we improve in those particular areas as well. So there's that again, make sure we're responsive.
When we're 5 years now into the journey, and we still have a very small, a reduced project team now. We've got that team in place until March 20, which is really supportive. I guess for me, being from a healthcare trust, is that often when we're in presentations, I try to sit at the back because I do like social BCSE calls to be at the forefront of this. It's that trying to not sell the NHS badge kind of, or if I'm there speaking, I have to think about it because it close to the NHS label.
I think it's important to obviously say it is very person centred. So we all, we get together as partners to have a look at what the needs are for each patient. Every morning there's a huddle where all partners get together and they discuss the needs and then find the best pathway for that patient. And that's pretty much at review at each time. So it's always open to bring back up a huddle and say, actually, we figured this isn't working. What other support can we put in place?
I think one of the appealing things from that model is it did take time from that inception of vision on values. And making sure that we're all aligned to those. That's what we come back to. So there might be disagreements, but we'll kind of bring it back to that just to make sure that's what we're adhering to at the end of this.
Slide 12 just really gives you some high level objectives, but really, I think we've mentioned that continuous transformation really. Working the barriers, because there have been times, certainly working with primary care, and certainly spend time at individual GP practices, kind of because there was a fear that we were going to withdraw services or that the traditional offer wasn't going to be there anymore. We obviously, it's good to see that we are supporting people, not just health needs, but the kind of complex needs to keep them well. And that empowerment really for the individuals, but also for listening back from their families and carers in particular. Reducing inequalities, previous conversation, but that is really important that we just continue those improvements and really just that we continue that collaboration supported by our ICB to do that.
across all.
It's good to see that, I think you mentioned Nottinghamshire, they didn't necessarily take community mental health very well forward as we've done. And it's good to see now that they're looking in to see what we've done, so they can really see the benefits.
Yeah, I think nationally the implementation has been varied, but I think there's a lot of ways we've done this locally, and I think to recognise that to move forward with the 10-year plan in that direction.
Just also wanted to make the point, sorry, obviously we support people that are transitioning from 18 that then come to a normal service, and we also have to our all level as well. So that support continues.
Okay. Are we ready for questions? Councillor Repton.
Yeah, looking at the living well beyond mentalisation, living well after short-term care for 12 weeks. What happens with somebody who doesn't fit the next 12 weeks who needs to go beyond 12 weeks?
We accommodate that. We need to talk on that a little bit.
Yeah.
So it's not a total cut off. That's the injuries.
I don't know why it's mentioned then.
Well, that's kind of the idea that we would that 12 week, and that's would be less friendly. We will support 14, 16 weeks.
Obviously, as you're aware, people's needs vary, and sometimes it can be weeks, months, years, can't it? Is that made clear to
if they've got
service users?
Yeah, and if they've got a significant health need, then we would still support them as a long-term offer to the traditional with the CMHTs. Well,
Yes, I think it's important to mention when we do speak to our patients, it is very clear that it's a 12-week off just to manage their expectations. But equally, we do something called a recall. So we have a look at where they're at the beginning of their journey, the midway, and then at the end of it. And at any point we feel like the goals are not being met or the needs have changed, because we're always assessing risks, and with mental health risks always change. So we then assess the pathway, we then assess their goals, and we take it back to the huddle, which is daily, and we have a discussion between all three partners and say, right, is this the best care for this person? Should we keep them under ourselves for an additional 6 weeks, whatever that looks like? And then it is pretty much from there. If the needs end up being more severe or the risks end up being more severe, we probably will then look at other avenues, whether it's a long-term offer, depending on what that is. But most of the time, yes, we are catering for them past those 12 weeks if it's necessary.
Yeah, because it's I've worked at both Pastures Psychiatric Hospital, Kingsway Psychiatric Hospital, community mental health teams. So there's been a big journey from, thank God we've gone from the days of the 1960s where people were in hospital for 40 years, but saying from 40 years down to 12 weeks, it's so it was making sure that it's sort of we're not rushing too much. We're making sure that people's needs are actually met, which are often complex. So, yeah, that's ratio. Okay, thank you very much. Thank you.
Did I see Councillor Lonsdale?
So I've actually been a recipient of yours twice. Once before this 5-year programme and once midway through. And I accessed talking therapies. And I can say that in that midway through point, the change and the improvement was vast. The one thing that I wondered about was the different ways of accessing the service. Back before your service, it was literally the doctor gave you a telephone number and you had to phone it, which was a huge barrier. Midway through, it was a bit more easy to access. Has that improved? Again, I mean, I would say it could have been improved then as well. So is that something you've improved or looking to?
We're certainly looking at improving all the time. I think one big difference in this model is actually those peer support workers that can really lower that threshold of getting people to actually come out and help people. And I've seen that work in live, in action as well, where people who might have had real difficulties in getting out of the house, even the peer support workers working with people really makes a huge difference.
Well, if you've got a mental health issue, asking you to pick up the phone and call is not going to do it. So yeah.
Well, this is one of the reasons we have welcome calls. So the welcome call is there just to almost alleviate that tension. So if you've been referred by your GP, a different professional, the first thing you'll have is a welcome call, and that's someone ringing you or contacting yourself to say, okay, do you know you've been referred, coming through, just basics really. And it might be that the intention of referral was different to what your expectations were, so it's some of that conversation as well. But that is really about being proactive, trying to take a no wrong door approach, and getting the best outcomes for the individual, matching this with expectation.
Yeah, no, that sounds.
I think also it's important to say that obviously Derby is one of the localities where we have something called a cloud visit, and that's pretty much where we get everyone together in a room, and we have a look at, you know, there's people with lived experience, there's people that are other BCSEs, you've got support there, you have our health fair, you have, you know, just a combination of people. And at the moment, what we're doing with that is we're optimising that space to see referral pathways, to see what that looks like to help that flow. So it's not just then, you know, reliance on just GPs, it's having a look at how other, you know, community workers out there can actually look at that. I think what we are doing with that space as well, we started to implement it, is utilising that space to actually co-produce things in Derby Living Well, so whether that is a referral pathway, whether that is, whatever that looks like, you know, the welcome calls is being one. How does that work? So we're taking it back to the collaboratives and saying, actually, you know, what's your thoughts on this? We have a lot of lived experience there. We have separate lived experience forums that we are still continuing to actually hear their voice. We want them to really very much be a part of this because they have actually produced this.
So yeah, we classify various organisations together in common interest as well, serving the population of Derby. So, you know, the University of Derby there, different voluntary sector, community sector organisations, coming together, sharing ideas. I suppose just an open invitation to members here. You know, if you want to come down to a collaborative, you're welcome to do that as well. Monthly at the West Indian Community Centre, and it's a real positive space where we discuss different strategies on supporting mental health in the community.
You still do the you still do the employability support afterwards as well? Then that was a helpful.
Yeah, so
Councillor Ashby.
Thank you very much. That's really, really interesting. It sounds like you're doing great work really, and really, you know, providing. I just wondered, so is access by GP referral as well as the self-referral for those who've already been through it?
So it's self-referrals for anybody who's been within the model 12 months. It's primarily GP access at present. You can come through other parties, so like, for instance, if you come through social care, we'll then introduce you to that model if that's what you need. We're working on expanding the referral pathways. However, we're trying to measure that against what our current capacity is. So it's always a fine balancing act. So once you kind of open the doors fully, you don't want to be overwhelmed where we're not able to provide that.
So do GPs then have to assess and analyse which patients should be told to self-refer to talking mental health and all of the other organisations that do counselling, and which people need to come through this pathway? Or was one question. The other question is capacity issues, which you touched on.
I mean, we've done lots of work with GPs to kind of make them choose the right. If they choose wrong, we often speak back with them.
So they do have to choose the right patients.
Yeah, it's I think in the main to get the right pathway, but if somebody comes through to the living well, often we feel actually they could have gone through the talking mental health, but we'll speak back. I mean, it's having that direct dialogue. What I try and not encourage is letters going between. It's about picking the phone or Certainly within our trust, we're trying to enable, say in Derby City, we've got psychiatrists certified, and that's what it's about, them having relationships as well with primary care and, you know, colleagues from, so they've got those connections based. So I'm not sure they can.
We've got some mental health roles in primary care as well, helping with some of that navigation as well. So helping primary care colleagues to navigate the vast services that we've got and help with that. And there's educational sessions for PCNs as well, where we regularly go and update part of that education.
We talked about the collaborative. We also engaged with Derby City Neighbourhood previously in place. So I sit on there. So there's certainly Dr. Davidson. There's certainly 3 GPs that are regular members. So again, that's just a really good platform. So periodically, you know, again as a team, we'll go and give them an update.
And do you have capacity issues? Are you able to, you know, alongside that waiting times, really, are you able to work with all the people?
Just to probably give a more operational view on that. Yes, we do have waiting times. At the moment, we're seeing everyone within our average wait is within 28 days. So that is kind of really positive, which is why we don't want to. So that's 28 days from initial contact, from referral to initial conversation. So we'll speak to someone, have a conversation with someone's needs within those 28 days. There is a longer waiting list for intervention depending on what intervention age we're bring down, make sure we manage that, and we meet monthly as a senior leadership team to look at what the waiting times are. And again, what I was saying earlier is about flexibility. So what can we stop doing to enable that speeding up that contact time to make sure we're doing things, and we're actually paying fidelity to the model, which is that preventative. So the longer someone's left, their needs increase. So we try to keep that as short as possible.
Thank you very much.
Any other questions before I get on my little soapbox? Okay, so yeah, for me this is quite close to my heart in terms of some of the reasons I became a counsellor in the first place, around mental health support, and within this lovely circle diagram you've got drugs and alcohol, autism, young people, early interventions, psychology, all of that is around the outside. And that's just what I dealt with personally, and I think it's for me, it's all well and good having this centered approach of this one person, but the impact that has on families and the impact that you. So my sort of question is around if you're working with this one individual, how are you or we as a whole supporting the fact that you're going to have genetically likelihood that people have got similar issues within the families. You've got the impact of what's happening with them having on other people within that family. And as the impacts of that you touched on here on legal help and work support and various other things that happens. I just think for me, if you want to answer me that first, if you are seeing that if you often get one individual that you're working with, how is that helping in terms of, are you working with families as a whole, or is it just based on individuals?
I would say it's based on individuals. It's a conversation we were having recently within one of our team meetings, actually. So yes, it is focused on that individual. But like with any conversation, you know, within conversation, people do mention personal circumstances that do family members. And I think, you know, we've got those, I guess, expertise or connections to actually direct people to that level of support. So even though we can't really, without going into GDPR, we can't really go into other people's personal issues, but if there is something like a carer, for example, carer burnout, we know where to signpost those people or provide that wider support, I guess. But that's just something that obviously we've picked up recently, that yes, even though it's based on the individual and the focus is on the individual, in conversation, sometimes things are mentioned which we can't really turn a blind eye to. So whether it is they've mentioned it's debt or something, anything, right? We will then have a look at where that support is. So even though we're not directly supporting that family member, directing them somewhere for that support.
Yeah, and it's about working with that person within their system. So it's not just necessarily family, so whoever supports that individual, talking about who are the key people in that person's life, who they're connected with. So that's a real key focus of the model. So those circles are in isolation, they're part of that individual system and the way they conduct their day-to-day life. And we operate in a very carer-aware fashion. I mean, Citizens Advice are the local authorities commission partner around carers conversations. So there's that connection already there around carers, and Derbyshire Healthcare are part of the Triangle of Care initiative. So looking at carers, and we're partners to that as well as local authority. So we do look at that carer space as well quite closely, and working on that quite profoundly as well.
And I think that's where the collaboratives is a really good space, because we get all sorts of different organisations in that space, and it's not always just about that individual. We do get people that are family members and carers or people that are affected, and they want to know what other support there is out there, you know, for them, whether that's because they're supporting a patient themselves. And it's not necessarily that this patient is a part of Derby Living Well or Living Well as a whole. It's just that they've come into a space because they are caring for somebody that's going through mental health. So I think that's where we're trying to optimise that space for, I guess, us elements like that. It's probably not like it says directly to that person, but there are elements at that collapse what we're trying to optimise really.
Before you come in, back in the day, it used to be Team Around the Family. Don't know if that rings any bells with anybody.
Children's services where you have to have meetings and Team Around Families.
Team Around Families.
Affects one children, but
yeah,
again, that triangle of care focuses on us as the professionals, that individual, their carer, family, and kind of making sure those connect.
It picks up for me where does it, because we've got our educational healthcare plans are from 0 to 25. So our kids that are identified as having various health concerns, which often it can include mental health concerns, they're hitting the 0 to 25. So they're on children's services till they're 18, but then they're in adults from 18 to 25, but still got. But in terms of, and I've mentioned this in a previous meeting, we've got a CAMS service that has a 2-year waiting list. So a 16-year-old now, I may or may not know one who lives in my house, is on a 2-year waiting list. So by the time he gets the support or whatever, he's then fallen into adults. So are we aware of, as a service, that you're going to have this pressure that because it's not being met within a CAMS service as it stands at the moment, you're going to get that within the adult service?
Yeah, and I think that is something we're very acutely aware from the neighbourhood perspective as well. So, you can looking at, there is that pressure coming from younger people who are having poor mental health, and how that then relates to adulthood.
How that impacts from a 16 to 18, which is a young adult in my view.
Yes.
You get into that. That's where you learn you're not engaging. You're not then getting the qualifications. You're then becoming an adult with even more complicated lifestyles. And I just think we're missing a big trick here. That for me, when we are aware that there are mental health issues at a younger age, we need to have that support far earlier than waiting till they're struggle with employment that you picked up earlier. They're struggling with education because they've not been able to access that through anxiety, or whatever reason it is, when actually if we could support them at a much earlier base, we've got a far lesser chance that these are lifetime people who are struggling with long-term health.
And the 10-year plan has a real focus on that preventative and early intervention path as well. I think we need to be even earlier.
And the impact that has, and as I mentioned around families earlier, we've talked about how this is based on Derbyshire. So it'd be interesting to know how many we have in Derby that you're supporting. What your you said waiting times of 28 days, but that's I presume as an initial contact type scenario. It's not necessarily the starting with a specific service or whatever.
It will be for what we call an initial conversation, which is an assessment of that individual's needs and outcomes. So it will be identifying goals and the appropriate interventions. So again, I think depending on the intervention that's required, whether that's with a peer support worker, with a social worker, with a community psychiatric nurse, or one of our therapeutic groups, those will vary to those and figure out within that.
Yeah. You talk about collaboratively working, and I've had lived experience of a situation where you've been through the GC. On this page here, you've got your self and community assets. You know, we are often signposted to lots and lots of things, but it's accessing those, as you pointed out, with barriers in your life in terms of what you're dealing with day to day. People aren't necessarily able to access them because they are either dealing with the current crisis that they're dealing with, having to manage work or the family, etc. So they're not accessing that because they're unable to do so at the right appropriate times. And then you've got the GP. So you're going to the GP when you're at minor crises, or you're identifying you've got issues and you're identifying you're struggling. And then you're getting talking therapies, and within, you know, you're being put into different things. Then you've got the community mental health advisors, which I personally haven't had any signposting to. It's been talking therapies, etc., go through the NHS. And then when you're at real true crisis, it's ring 111. You get through to a mental health nurse who's then saying, oh, I'll put you through to CAMS. I said, I'm already waiting for CAMS, or you know, you're already on the waiting list for talking therapies, or the situation's escalating. And then you get caught, then it's escalating to physical or other situations that are not ideal, and their port of call is ring the police. And then the police aren't in the capable, that isn't for me the right place for those individuals, because you know that they're struggling, you know that it's a mental health crisis, you know that that's impacting on the situation at hand. And then when you do call 999, they put you through to somebody. It's very much a pass the book. And I hate to say, you know, it's great to hear all these positive lived experiences where we are seeing improvements, but I would argue the fact that for all these brilliant work that you're doing, there's probably 100 families out there that are going out there in complete crisis, and to the point where they are literally having meetings at work tomorrow about their attendance and stage 2 whatever's. You know, the impact it's having on families and crisis levels is immense, and that's whether it's a young adult of 18, got one of those, or a young person of 15, both struggling with similar scenarios. So for me, my worry isn't it's great what we're doing, but are we doing enough of it, and are we getting to the right people at the right times?
There's clearly there's clearly still a lot still to do, and I really recognise that increase in mental health presentations, particularly in our younger people as well, and our sort of adolescents as well in that space. So that's probably a whole separate topic probably to talk about what our vision is around children and young people and access and early intervention.
It's different people at different ages, doesn't it? Especially when you're talking, you mentioned about autism and other neurodiversities, that their age appropriation of hormones, all of that may hit at an adult stage that they're dealing with, that would have dealt with as a child stage. So again, those sort of scenarios are coming in here where you've got that problem.
We've done a lot of work with police colleagues as well around right care, right person. So making sure that we don't have people necessarily going down the police route, and we've got other practitioners, mental health practitioners from Lee's team or the ambulance service or other opportunities that we've got. Really focused on that in the last couple of years to make sure we get the right mental health practitioner involved rather than that. I think
we've also had the introduction of the mental health recovery vehicle as well. It's out there on the streets. So since that vehicle's been out there with paramedic and nurse, we've seen a significant reduction being taken to either the 136 suites or the A&E departments, which is brilliant.
And that's great for those that,
Yeah.
for me, I think you touched on it earlier, that you've got this gap, you've got this very fundamental basics, just need anxiety, support in general. You've got this high need, really we are targeted, you've got these people, you've got this gap where people are falling down in the middle. And that's a tricky one to deal with.
So better work to be done.
Yeah, I think so. And I think, what we do try and do here is, especially with the peer support workers and the wellbeing coaches, is that soft welcome, if you want to call it, rather than just, we're aware, especially if you've got mental health and let's say autism, giving information, it's not going to get retained. It doesn't matter how much the intention is there, we all know that that information is not going to get retained. There's a higher chance that individual's not going to go for that support because that's one of their traits, isn't it? So what we do is we do that warm welcomes, whether it's something that we're introducing to that service by a telephone call, whether it's a referral to that place. I think we take it, we want to make sure that these people, if there is support in the community for them, our patients are actually getting that support, as opposed to saying, here you go, this is our goal, and this is what you wanted, go and ring these people. That's not the idea of what we're doing here more than anything. That's it, more instructions.
If I can just say, I completely agree with Councillor Rawson that people who've contacted me have had similar experiences about this lengthy or unreasonable delays in terms of getting the support, then the problems escalate to a stage it shouldn't be going to. Now, I understand it's about resources, but also it's about use of those scarce resources. And I know the difficulty you've got, and it's great you're going to take it on board, but I think it's somehow to come back to our committee and say, well, I've had a deep dive into this, because these plans are absolutely fine. The lived experience of people in the street in Derby is that they're fearful of those incredible waits that they get and won't get the response that they actually need, and they don't get the crisis intervention they need at that moment in time when it's actually asked for. And so somehow I was trying to say, well, look, this is the lived experience. How can you start to address that? What is needed, and over what period of time can it be achieved? Where do you start?
Yeah, I think we could definitely, I certainly could go into a lot more detail of lived experiences and not just personally, but other people's things, and I'm willing to do that with anybody who wishes to listen, but I don't think we could drag this meeting on too far. So I'm going to ask Councillor Ashby to support any other questions that we might have.
Really gone off what you're talking about onto the huge problem that we're all aware of, painfully aware, with the lack of CAMS provision, really. It's gone on for years. So my question is, what's happening to improve that provision? This is mostly said, we don't get in there now, we'll never fulfill these later because they're always escalating.
Yeah, it's certainly something we can.
There's a couple of pieces of work that's happening. I mean, we have just received funding specifically for camps to address access. So we will be working closely with colleagues to kind of work through what that looks like. The other big piece of work that's happening across the system is there are various number of providers providing children's services. So again, rather than think, because we provide universal services as well as the health veterans, which teacher help us and skilled nursing, and the council to give the EHS. So again, that's just an example where we're trying to work collectively to understand what do we need for our children across Derby and Derbyshire, and then try and work out who's going to provide it long term, whether it remains. It's just work, yeah.
It's a bit, again, I don't want to get too self-involved in all of this, but a friend of mine has recently struggled with a similar situation, and she's ended up going to I'm not going to name names, external provider and paying privately to get support quicker, and that's great for those that can do that. But then for me, my concern is there's lots of people who can't afford to do that, who may be in more severe crisis or situations, and those people are being utilised for other systems because of qualifications and experience. So yeah, it's a minefield.
And the problem has been only for years, as long as I can remember. I've been in general practice. The provision for camps has been inadequate. and has never met need. And it's just got worse and worse and worse. So how quickly are we going to see improvements? Because
we know that I think the point that we're making is that this will have a massive impact and has historically been probably one of the main reasons for this big increase now of adults, young adults we're having in crisis.
It's probably a topic that we may need to take.
We need
that we bring that. We've talked about this today, haven't we? But clearly, we're children are our adults of the future, aren't they? Really? So
I think the recommendation for children in that.
yeah.
Okay, thank you very much. I think we've got one final item for us as a board. Just to quickly go through our work plan refreshment. We've just got a couple of that if everybody's okay with. We've got the general update on dentistry and the Derby and Derbyshire children and young people's mental health and emotional well-being. Say that quickly. That we would like to bring forward to a January meeting, and it may mean that some items from January to April, and we will. Is everybody happy with that?
Yes.
Excellent. Thanks very much. Thank you, and I'll close the meeting at that point. Thank you.